Hello, my name is Madiha Ahmed, and it is a pleasure to present at the ACP 2023 poster competition. A shot through the lungs into the brain, a rare case of coccidioidal meningitis. A 22-year-old male with no known past medical history, who had recently moved to the United States from Guatemala, presented to our facility complaining of intermittent headaches, memory loss that had been going on for a week, which had recently progressed to vision loss. His vital signs were within normal limits, and labs showed a normal leukocyte count and normal inflammatory markers. HIV and RPR was negative. The CT scan of the head showed diffuse subarachnoid hemorrhage with significant hydrocephalus. Patient underwent emergent EVD placement. This was followed by CTA of the head and neck and a cerebral angiogram to localize the source of the bleed. However, both studies were negative for an aneurysm. An MRI brain was then performed, which can be seen in Figure 1. It revealed thick leptomeningeal enhancements throughout the basilar cisterns concerning for TB meningitis and leptomeningeal carcinomatosis. We performed a pan-CT scan to identify any underlying malignancy. However, the scans were negative for a tumor. It did, however, show a cavitary lesion in the lungs, as shown in Figure 2. Due to concerns for tuberculosis, we performed a gold quantiferon test, which was negative, hence ruling out TB. The rest of the infectious workup is summarized in Table 1. We performed a lumbar puncture, and the CSF fluid analysis showed a lymphocytic pleocytosis and elevated RBC count. CSF cultures had no growth. CSF meningitis and encephalitis panel was negative. Functional assay was slightly elevated. Histoplasma, cryptococcal, and blastomyces antibodies were negative. However, the coccidioides IgG showed a titer of 1:512 coccidioides antibodies, yielding a diagnosis of coccidioidal meningitis. Patient was started on IV fluconazole 800 mg daily for 4 weeks and then transitioned to long-term PU fluconazole. He had a close outpatient follow-up with infectious disease doctors and made a full recovery. Coccidioides is a systemic infection caused by dimorphic fungi. The geographic distribution of coccidioides is the Sonoran Desert, which includes the deserts of the southwest United States, which includes California, Arizona, New Mexico, Nevada, Utah, and Texas, as well as Central and South America, as seen in Figure 3. Coccidioides is acquired by inhaling spores in the air. The biology can be seen in Figure 4. In the environment, coccidioides exists as a mold with septate hyphae. These hyphae can fragment and are inhaled by the susceptible host in the form of arthroconidia. This forms spherules in the lungs of the host, which can rupture and release endospores. These endospores disseminate in the surrounding tissue, causing systemic coccidioides. Coccidiomycosis can present as highly variable symptoms, ranging from asymptomatic to severe disseminated infection and even death. CNS involvement has a very high morbidity and mortality and can cause various life-threatening complications, one of which is subarachnoid hemorrhage. Most cases of subarachnoid hemorrhage in coccidioidal meningitis are seen in the setting of aneurysmal rupture. Interestingly, the mechanism of subarachnoid hemorrhage in this patient was non-aneurysmal from arachnoiditis or local vasculitis. This case highlights the rare localization of the fungal infection in a baseline immunocompetent patient, as well as to spread awareness among healthcare professionals to help with a prompt diagnosis. Thank you so much for listening to this presentation.